Thank you, Dr. Katskaris and Dr. Chow. It's a pleasure to be back here at the St. Michael's Hospital Echo Lab and to talk to you today about aortic stenosis. Dr. Chow pointed out that in the vast collection that there wasn't a recent talk on the basics of aortic stenosis, and so that's the goal of today's talk, is to review a lot of the parameters that we use to assess AS. So I personally don't have any disclosures pertaining to this educational presentation. The figures and images are sourced from literature and textbooks with citations, and the echocardiographic clips are courtesy of the St. Michael's Hospital Echo Lab team. Our objectives today are to review the assessment of aortic valve morphology, review standard transthoracic echo measurements for the assessment of AS, and discuss common caveats to echo parameters of aortic stenosis. There are some related educational presentations from recent St. Michael's Echo rounds, which are quite related to this talk, including the assessment of prosthetic valves, the physics of echocardiography, and the evaluation of aortic regurgitation, which have all overlap with this talk and important considerations. A little bit of background about aortic stenosis in terms of the epidemiology. In North America and Europe, calcific disease of a trileaflet or bileaflet valve or bicuspid valve is the #1 cause, but rheumatic aortic disease remains quite prevalent worldwide, though it's most commonly associated with rheumatic mitral disease, harder to miss. The prevalence, as we know, increases with age, and there's a bit of a breakdown as you age in terms of the distribution of how many valves are tricuspid and bicuspid. And these numbers here are excluding rheumatic valves, but as you can see that for people with significant aortic stenosis of age below 50, it's mostly bicuspid or unicuspid valves. As you age, that proportion shifts towards calcified tricuspid aortic valves, but there's certainly an overlap period. And as we know, bicuspid valves can degenerate sooner and also become calcific, which muddies the waters a little bit. This is an illustration from Baumgartner et al., which shows some of the different types of valve disease, 3 most common types. On the left, we have a normal appearing valve. Then we have what we see is a rheumatic appearing valve with fusion of the commissures between the leaflets, calcific valve, and a bicuspid valve. To assess valve morphology on echo, the best view to look at is the peristernal short axis at the level of the aortic valve. You can get some information from the peristernal along as well. For example, with some bicuspid valves, you can get leaflet doming or asymmetric closures, but you can also get asymmetric closures if the view is off axis. So you don't want to be fooled, and you want to make sure that you're looking at your peristernal short axis. Sometimes with some patients, we have poor peristernal windows. And so another place to look, you can actually have a modified short axis in the subcostal views, and you can try to assess the valve there if you're unable to obtain good windows in the peristernal. The diagnosis is most reliable when the cusps are seen and assessed in systole, because when you're in diastole, you can have things like a bicuspid valve with a raphe that appear to be tri-leaflet. But once the valve opens, you see that some are fused and that you actually have a bicuspid valve. This is an illustration from Nicolas et al. Showing the orientation of the cusps that we see on a short axis view. So the right, left, and non-coronary cusps. And this is the Siebers classification by Siebers and Schmidtke from publication in 2007, which helps us sort of classify the different types of bicuspid aortic valves. Type 0 would be no raphe, which is a true bicuspid valve. Type 1, which is the most common type, has 1 raphe. And as you can see, type 1 is subcategorized type 1A, type 1B, type 1C. Type 1A with fusion of left and right cusps is the most common type. And type 2 is a valve with 2 raphe, which is functionally unicuspid. Now, if you're looking at this picture and you're saying, hey, wait a minute, that orientation is a bit different from the illustration you showed me on the slide before, that's because this is the surgeon's view. So not to get confused, this is with the left coronary sinus on the left side, not the echocardiographer's view that we see in peristernal short axis. So to put something in perspective that we're more used to looking at when looking at echo, this is a figure from Kong et al., which takes that same Sievers classification, but reorients things in a way that we are more used to seeing with the orientation of the right, left, and non-coronary cusps. And this shows, again, the opening that is expected. So I thought we would take a look at a few valves. I don't know if there's a cardiology resident or fellow that's available. There are no tricks, I promise. Is Brendan there?
I can take it if you want, Nick.
Nope. All right, Foti, please go ahead. What do you think of this valve?
So I guess we're looking at a loop of a parasternal short axis through the base of the heart. The aortic valve looks like it's probably trileaflet to me. There's evidence of three kind of deformities of the aorta, which are consistent with the sinuses of Valsalva, so they go with the cusps. Yeah, I think this is a well-opening tricuspid valve.
Completely agree. This is a normal, well-opening tricuspid valve. And here's another
tricuspid aortic valve.
Correct. That's correct. Trileaflet aortic valve, tricuspid aortic valve. Very correct. What do you think of this one, Foti?
Yeah, so this one's a little bit more challenging because it's not as well visualized, but what we can see here is that the opening appears to be more horizontal. So the opening looks like it's kind of a 3 o'clock to 9 o'clock opening. So this is probably a bicuspid valve. You also lose those kind of three nice sinuses of Valsalva that we saw previously, although it's not well visualized. The only thing that I can't say for sure on this is if it's a quote unquote true bicuspid valve versus a raphe of one of the other valves. I don't see any other raphe, so I think this is probably a true bicuspid valve, but I would need more views to make sure.
And that's exactly it, Foti. So this is a bicuspid valve, and as you've said, it can sometimes be hard to see if there's a raphe or not, and it's possible to miss it on echocardiography. Sometimes imaging has to be supplemented with CT or MRI, but you're exactly right. This is a bicuspid valve. And what about this one? A little bit more in the way here.
Yeah, so this one is interesting. You know, it almost looks like there are four cusps. It's kind of, sorry, my imaging on the Zoom is very choppy, so
no problem. I won't this is intended to trip you up to illustrate the point that because bicuspid valves can degenerate and calcify like trileaflet valves, it can sometimes be quite difficult to assess it on echo. This, because of the chunks of calcification, looks like it could be 3 cusps, maybe 4 cusps. Turns out that this is actually a bicuspid valve with big chunks of calcium, so calcification of a bicuspid valve. And this illustrates that sometimes we can't necessarily be certain with echocardiography about the morphology of the valve. So it was supposed it was supposed to cause a pause, which was by design. What do you think of this one, Foti? This is in the parasternal long, as you know.
Yes, so like you mentioned, this is a parasternal long axis. It's very abnormal in its movement. I will say that this is a much, like you said previously, this is a very challenging view, right? Because we don't know if we're just off of the center of the valve and we're looking at one cusp, but there's certainly an asymmetric closure. There appears to be some doming as well of the valves. It doesn't look like it opens up nicely. You know, you'd have to kind of look around to see what the company it keeps. You know, this could be a bicuspid valve. This could be an off-axis normal valve, although I don't believe it to be, or this could be rheumatic involvement of the aortic valve as well. But on this one view, it'd be hard to make a diagnosis.
That's exactly it. You hit it out of the park, Foti. So this is the same valve seen in parasternal short.
Yeah, so
I can slow it down for you.
it's not that, yeah, it's, you could, it's not going to help. There's, you know, The thing that I noticed here, oh, well, there you go. So that's a good shot there because it looks like it's one valve. It looks, sorry, well, it is one valve. It looks like it's one, probably a unicuspid or a fusion. But there are three sinuses of Valsalva. So this could be someone who has calcific aortic disease, and there's fusion of all the raphe. So looking more like a unicuspid valve, but I'm happy to be corrected.
No, you're totally on the money, Foti. So this is a type 2 bicuspid valve, hard to see for sure on the echo. And so it comes, it acts as functionally unicuspid. So to your point that you're suspecting unicuspid, this one has two raphe. So that defines the type 2. And there's a raphe between the right coronary cusp, non-coronary cusp, and another raphe between the right and the left, which gives you that appearance of a unicuspid valve. All right. And this is your lucky charm, Foti. This is the last one, I promise.
This is the lucky charm. This is the quadricuspid, yeah.
Yeah, so this is a beautiful quadricuspid valve that came through the lab with some calcification of the leaflet tip. Thank you very much.
No problem. I think it's an interesting side point. Just seeing the sinuses of Valsalva on the previous aortic valve kind of gives you the idea that it didn't start off as a unicuspid valve. You know what I mean? It started off early in life as probably a tricuspid valve, and then over time started to create raphes. Whereas, you know, there are other aortic valves that don't have these nice sinuses of the Valsalva because they're associated with aortic root pathology, which is kind of.
Yeah, they are different things. That's why we're saying functionally unicuspid, and this was a bicuspid valve of two raphe, to your point. All right, thank you, Foti. So this, I'll take it from here. This is a peristernal short once again. And here we see that the non-coronary cusp is thickened and quite restricted. It's not opening well, although the two other ones are opening quite well. And I'm going to use this to illustrate the point I made earlier about, let's say you couldn't see this on the peristernal window. Let's say you had a bad window. You could look in subxiphoid or subcostal. And I apologize, this is not a zoomed image, but if you take my word for it, we're looking through the liver. And then you can see in the sort of center of the heart, that same appearance of that restricted and thickened non-coronary cusp. So you can assess, although it's not ideal, you can assess aortic valve morphology, at least to a certain point in the subcostal view if you don't have access to the peristernal windows. This is a modified short in subcostal. So a little bit more background. Aortic sclerosis, thickening, degeneration of the valve, and stenosis, where do we draw the line? So stenosis is when your maximal velocity across the valve reaches 2 meters per second. And according to the 2020 ACC AHA guidelines for the management of heart disease, they've classified aortic stenosis in different stages, stage A, B, C, and D, with subclassifications for C and D. Stage A is at risk of aortic stenosis. So these are patients with bicuspid or other congenital abnormalities or aortic valve sclerosis, but that Vmax, that maximal velocity, is less than 2 meters per second with enough leaflet opening that you're not generating these gradients. Stage B is progressive AS, and this incorporates both mild and moderate aortic stenosis. The mild stenosis is defined as a Vmax of 2 to 2.9 with mean gradients of less than 20. And moderate aortic stenosis has a Vmax of 3 to 3.9 and a mean gradient of 20 to 39. This is from the ASC 2017 guidelines for the assessment of stenotic valves. And if we look to the right of the table, we see those magic numbers that we all try to remember for severe aortic stenosis and good for junior trainees to learn. So peak velocity, so Vmax for severe, is when you've reached 4 meters per second, a mean gradient of 40, aortic valve area of less than or equal to 1, an index aortic valve area of 0.6, and a velocity ratio of 0.25. And we'll get to all those measurements in the presentation. This is a classic illustration, and I've taken this one from Up to Date to remind us, why does this all matter? And it's very important to get this right and to follow these patients with close monitoring and timely intervention, because it actually saves lives. As we remember, severe aortic stenosis has an asymptomatic stage, and at the advent of symptoms, there's a dramatic drop in survival, as we can see here with the cardinal symptoms of heart failure, syncope, and angina, but important to also think about decreased exercise tolerance. This is the stage C of aortic stenosis, and this is the asymptomatic severe aortic stenosis that we see in the guidelines. This is defined by a Vmax of 4 meters per second or more, and a pressure gradient, mean pressure gradient of more than 40. The aortic valve area is typically less than or equal to 1 centimeter squared, or an aortic valve area index of 0.6, but this isn't required to define severe AS. And of course, stage C2 is the same, but with an EF of less than 50, and that comes back to indications for surgery. Finally, we have stage D, which is symptomatic severe aortic stenosis, and this is subclassified in 3 categories, including symptomatic severe high gradient AS, which is the AS you expect with a low aortic valve area and a high peak velocity and peak gradient, as we discussed. D2 is the symptomatic severe low flow, low gradient aortic stenosis with reduced LVEF. This is that classical low flow, low gradient. And this is when you have an aortic valve area of less than 1, which suggests severe AS, but your velocities or gradients are not reaching that severe cutoff. And the patient has an EF of less than 50, suggesting that they don't have the forward flow to generate the adequate measurements. Now, to rectify this, we do a dobutamine stress echo, which, if the valve is severe, shows that the AVA remains below 1, but the gradient increases and the Vmax increases to 4 or more. And we'll come back to this later. Finally, there's stage D3, which is symptomatic severe low gradient aortic stenosis with normal ejection fraction, also known as paradoxical low flow, low gradient severe AS. And again, this is when your aortic valve area suggests that there is severe aortic stenosis. You have an EF greater than or equal to 50, but your gradients are not meeting severe criteria. And you find that you have low flow by assessing the stroke volume and finding a low stroke volume index. It's important to take these measurements with a normal blood pressure because excess blood pressure increases further afterload on the LV, which can reduce your flow. We'll come back to this as well. So the 3 key parameters in assessing severe aortic stenosis is your Vmax, or your peak jet velocity, which we obtain with continuous wave Doppler, your mean pressure gradient along with the stroke volume index, and the aortic valve area by continuity equation. So how do we get these measurements? The Vmax is found using continuous wave Doppler at the maximal point. So you want to assess multiple windows, your apicals, your right parasternals, your suprasternals, to find the jet that is the highest, because you want to be parallel flow and you don't want to miss an eccentric jet. The max velocity is commonly found at the right parasternal window, and so we can't just be looking at apicals. It's also important to, when possible, report the window where you found the maximal velocity so that it can be compared on future studies. It can be helpful to look for the color Doppler alignment to try to find your orientation that's most parallel with the direction of the color jet. It's recommended to also use a blind probe, a non-imaging continuous wave Doppler transducer, which is smaller. It can fit between the rib spaces and also has an excellent signal to noise ratio to try to find that highest velocity. This is for Dr. Chow, who's an aficionado of medical history. I've put a classic, clearly hand-drawn illustration from Nishimura et al. From the Mayo Clinic proceedings from 1985 that show us the different positions, the different windows where you want to assess your velocity there. And the key to this is that if you underestimate the velocity, which is squared in the Bernoulli equation, which we're going to talk about, there'll be an even larger error when calculating the pressure gradient. So it's very important to get that velocity right. And of course, every measurement has caveats and assumptions. And when measuring velocity, some of the assumptions include that it is flow dependent and it requires a parallel alignment of the beam to the blood flow. Then when we're measuring or assessing our pressure gradients, we're looking at the peak pressure gradient, but that's not used to define severe aortic stenosis, and this is determined from the simplified Bernoulli equation. And your mean pressure gradient determined using velocity time integral and tracings of the Doppler envelope. So this is the apical four-chamber view, and we're looking at, on the left, pressure, we're using pulse wave Doppler in the LV outflow tract and tracing the envelope to obtain the velocity time integral, the area under the curve, to obtain the velocities and flows out of the LVOT. On the right, we have continuous wave Doppler across the aortic valve, which gives us our maximal instantaneous velocity, which is your Vmax. And as well, we trace the Doppler envelope here to obtain the VTI of your aortic valve. So to get to this point, we have had some assumptions which were discussed in the physics of echo talk, so I won't go over all the assumptions to simplify the Bernoulli equation, which brings us to the delta in pressure, the pressure gradient, being 4 times the square of the velocities. And the key is that if the proximal LVOT velocity, or V1, is less than 1 meters per second, which is commonly the case in stenotic valves, it becomes even smaller when squared, so it can be dropped from the equation. These assumptions should not be done when we're including a V1 that's more than 1.5 meters per second, or when V2 is less than 3.0 meters per second. So if it is not the case, then you can drop the V1 and simply have delta P equals 4 times V squared, which is what we're going to use today. Again, the assumptions of pressure gradient is that it is flow dependent. It depends on an accurate velocity measurement, as we talked about earlier. And of course, this is a simplified equation. So with our same patient, if we use our delta P equals 4V squared, our Vmax is 3.67, which is in the moderate range and more than 3, so we can use it in the simplified formula. We have a peak gradient of 54 millimeters mercury. But this is not what we're looking for when we're assessing the severity of the AS. We want the mean gradient. So to obtain the mean gradient, it's a calculation by averaging the instantaneous gradients over the entire ejection period. Luckily, it's quite simple to do this on echo because all you have to do is trace the aortic spectral Doppler envelope, and the software does its magic and does the integration for you. Next, when you're reporting your mean gradient, you want to make sure that you're also assessing the stroke volume. As we talked about earlier, you can have that paradoxical low flow, low gradient where your EF is normal, but in small or hypertrophied chambers, you can have a low stroke volume. And low stroke volume means low flow, means that your gradients might not be accurate. They might not generate enough flow to generate the pressure gradient. So with the stroke volume, the formula is quite simple. It's in mLs, or centimeters squared. Stroke volume is equal to the cross-sectional area of your LVOT times your LVOT velocity time integral, which we obtained earlier with pulse wave Doppler tracings. And finally, the stroke volume index is simply indexed to your body surface area. So for our case down below, I've plugged in the numbers, and we get a stroke volume index of 44.8 mLs per meter squared, which is normal. A low stroke volume index is defined as less than 35 mLs per meter squared, and we'll come back to this. Next is your aortic valve area calculation by continuity equation. The continuity equation is A1 times V1 equals A2 times V2, because you have preservation of your matter, your velocities, and your energy. And for velocities, we use VTI. You can actually also use Vmax. It may be less accurate depending on the shape of the Doppler envelope. And again, with every measurement, there are assumptions. The AVA is dependent on the accuracy of your velocity measurement, both for the aorta and for your LVOT. It's dependent on an accurate LVOT diameter measurement, which we'll come back to, and also the assumption that the LVOT is circular, which often it is not. And when we're obtaining diameters in echo 2D, we have to remember that this is potentially not representative of the actual 3D structure. So here we have the solving for A2, which will be our aortic valve area. A1 is the cross-sectional area, or CSA, of the LV outflow tract. And if we look here, we can see the cross-sectional area is defined as pi times your LVOT diameter divided by 2, which is squared. Your V1 is your VTI of your LVOT that we've obtained using pulse wave Doppler. V2 is your velocity time integral of the aortic valve using continuous wave Doppler, and we plug it into our formula. Before we do that, I just want to give a little shout out to the LVOT measurement, which punches above its weight, so to say. This is some recommendations from the American Society of Echocardiography on how to measure it. And it's important to do this in a reproducible manner and making sure that your LVOT measurements make sense from study to study when you're comparing studies. Because as you can see, when you have a difference in the LVOT, if there's an error, the error is squared. So if all your other parameters that you've plugged into your formula are the same, a smaller LVOT diameter will give you a smaller calculated aortic valve area. So sometimes when you're looking at studies and you see that there's a big difference, a big jump in the findings from, let's say, 2 studies that are a year apart, make sure that the LVOT is not what's accounting for the big difference in the aortic valve area. So remembering to trace it in parasternal long axis, in the zoom mode, in mid-systole, inner edge to inner edge. Coming back to our formula, if we take the data from the patient that we've assessed earlier and we plug it into our formula, we obtain an aortic valve area of 1.1 centimeters squared, which also falls in the moderate range. This person had a large LVOT, as you can see, at 2.4 centimeters. So we've assessed our 3 key parameters. There are 2 additional key parameters which I want to discuss with you today, including the aortic valve area indexed and the velocity ratio, also known as dimensionless index. So for your AVA index, very simply, you take your aortic valve area that we've already calculated and you index it to body surface area. And this is particularly important in the larger, smaller extremes of body surface area, similar to the concept of patient prosthesis mismatch, which Taylor talked about in another presentation. A smaller person may not need as wide of an opening as a bigger person. So it's important to remember to index these findings to body surface area. And here we have the cutoffs, with 0.6 being the cutoff for severe aortic stenosis. Next, we have our dimensionless index, which is also known as the velocity ratio or Doppler velocity index, DVI. So lots of names there, they all mean the same thing. And this is derived from the continuity equation as well. As you can see here, when you isolate for the velocities, you get V1 ratioed with V2. And the idea of this is to do away with your LVOT measurements and just keep just the velocities in the LVOT compared to the velocity that you've attained with your CW of the aortic valve. And here we have cutoffs again, with 0.25 as the cutoff for severe aortic stenosis. Some other important considerations when you're assessing aortic stenosis. Obviously, you want to complete the entirety of the assessment of the heart in the echocardiography study, but you need to think outside the valve. So the ventricles can be affected and also can affect your gradients. The size, thickness, and function of the LV are important to look at. Aortic stenosis, which is severe, increases afterload, which can lead to concentric LV hypertrophy as a consequence. And if you're looking at the LV systolic function, if it's reduced, it can cause low flow. A small cavity or hypertrophic cavity with low stroke volumes can give you paradoxical low flow, as we talked about. And you also want to look at the presence of other valvular disease, for example, aortic insufficiency, mitral disease, because this can affect both your assessments of the aortic valve, as well as you want to make sure that you're not missing other valves that are interventionable if you're sending someone for surgery, for example. You also want to look at the size of the aortic proximal aorta, aortic root, looking for aortopathies, which is particularly important in bicuspid valves and more common in bicuspid valves, but also for the concept of pressure recovery, which we will come to. You're also looking for other potential causes of obstruction because not all stenosis is valvular. I won't spend too much time on it, but I'll just mention that there are other causes for obstruction. Might be a good topic for another day. And some of these include dynamic LVOT obstruction, for example, HCM with LVOT obstruction, subvalvular aortic stenosis, such as a membrane or muscular ridge or combination, and supravalvular aortic stenosis, which is more rare congenital narrowing, typically at the sinotubular junction, for example, with Williams syndrome. Some other important considerations when you're assessing the aortic valve is the size of the aorta. So we'll get to the concept of pressure recovery. You're looking for states of low flow, so not enough flow to generate gradients, for example, reduced EF or small, thick LV with low stroke volume. And your stroke volume is affected by your preload, your contractility, and your afterload. So significant hypertension can add a second load on the LV, which can result in lower forward stroke volume and lower gradients. You can, just like you can have low flow, you can actually have high flow, which can give you an erroneously high gradients with only moderate narrowing. For example, if you have concomitant aortic insufficiency or AV fistulas with high flow. And in these cases, using your dimensionless index can be helpful because your flow will also be increased in your LVOT. And one common cause for potential errors, differentiating eccentric mitral valve flow from aortic flow because they both happen in systole. But the mitral regurgitation is longer in duration, starts with the mitral valve closure and continuing until mitral valve opening, which includes isovolumetric relaxation and isovolumetric contraction. Finally, the shape of the spectrum can help you comparing severe ES with chronic MR, but acute MR can give you a similar profile to severe ES, so be cautious with that. And of course, looking at your measurements and seeing where the cursor is pointing to. So the famous pressure recovery, and we have a portrait of or a painting or a picture of a painting of Bernoulli on the top right. So from Bernoulli, we know that pressure decreases as the fluid flow velocity increases. So let's take a quick journey of the blood's flow through the aortic valve. The blood's potential energy is converted to kinetic energy when crossing a narrowed valve, which produces a high velocity and a drop in pressure at that point. When blood enters the aorta, it then decelerates and kinetic energy is converted back into potential energy, which causes an increase in pressure. This is pressure recovery after the stenosis. Now, the caveat is that there's some lost energy because of heat generation from the turbulence and from viscous fluid friction as the blood flow crosses the valve and re-enters into the aorta. So in echo, the continuous wave Doppler samples the instantaneous maximal velocity, therefore gradient, prior to the pressure recovery in the aorta. So this might actually overestimate the actual difference in pressure from the LV to the aorta, which is the physiological gradient, which is what is clinically important. So in most aortas, the effect of pressure recovery is quite minimal because with a large enough aorta, there's more, this is me simplifying it, room for turbulence and energy loss, which leads to relatively less pressure recovery, which means then that the instantaneous maximal velocity is probably more representative of the true gradient from the LV to the proximal aorta. That being said, in smaller aortas, defined as less than 3 centimeters, there's less energy loss and therefore more pressure recovery, which means that the pressure gradient obtained with CW likely overestimates that gradient across the LV and the proximal aorta. And so again, a smaller the aorta, the less there's energy loss, the more there's pressure recovery. Thus, CW can overestimate the gradient in these cases. Now, this phenomenon of pressure recovery seems to plateau at an aortic diameter of about 3 centimeters, and that's why this is what's recommended in the guidelines and mentioned as sort of your cutoff when you're starting to worry about this. You can calculate pressure recovery, recovered pressure gradient, and energy loss index, but this will be for another talk for another day. The take-home point for today is consider that gradients can be overestimated by traditional echo assessment in small aortas due to the pressure recovery phenomenon. And you might say to yourself, well, 3 centimeters isn't necessarily a small aorta. And that's true for young patients, But as we age in our population of patients that are, in their 70s or even 80s with calcific aortic disease, the aorta over time will dilate. And along with patients with bicuspid valve, which is often associated with aortopathy, there will be a more dilated aorta. So it is more rare, but in younger patients and in congenital patients, this can be a more important phenomenon to consider. Low flow, oh no. So coming back to the flow concepts. So again, your low flow, low gradient, which is with a reduced LV systolic function defined as less than 50%. Your aortic valve area is low, which suggests severe AS, but your maximal velocity or mean pressure gradients do not meet that severity cutoff, and this is the low gradient. We use dobutamine stress echo, which if it is truly low flow, low gradient, severe AS, the aortic valve area will remain low, less than 1 or 1 centimeter squared in a severe fixed stenosis, but the velocity or mean pressure gradient will then increase to the severe level. However, if what you truly have is more of a moderate aortic stenosis with primary LV dysfunction, for example, from an ischemic cardiomyopathy, your aortic valve area will actually increase with the dobutamine stress, with the increase in flow to more than 1 centimeter squared. And so this is termed, or used to be termed, pseudo-severe AS. And the paradoxical low flow, low gradient. So paradoxical comes from the fact that there's low flow despite the fact that the EF is normal or greater than or equal to 50%. And again, you have aortic valve area or aortic valve area index suggesting severe aortic stenosis, but your gradients or velocities that don't meet the cutoff. And as we've done earlier, you're assessing the stroke volume index with a cutoff of less than 35 to suggest that there is low flow. This again is important as we talked about because stroke volume is affected by afterload, to measure your blood pressure with every echo and making sure that you're assessing these parameters with normal blood pressure states. If your blood pressure is quite uncontrolled, let's say your patient has a blood pressure of 175 over 100 and you're getting an SVI of, let's say, 34, it'd be important to control the blood pressure and reassess the echo parameters if you're in this state where you're considering low flow, low gradient aortic stenosis. It's also good for the patient to control their blood pressure. So this is a reminder that stroke volume is not LVEF, as you can see from the formulas. I've put an illustration here with patients, patient X and patient Y, who have quite different hearts, different size of end diastolic volume, who come to have the same ejection fraction, but have quite different stroke volumes and stroke volume index if they are of the same size. And you can see that patient Y has a low flow stroke volume index, whereas it is normal in patient X. So another consideration is your follow-up time. So the ACC/AHA 2020 guideline for the management of valvular heart disease suggests that for asymptomatic patients with a normal LV function, the frequency of echo monitoring, and this is not clinical monitoring, this is echo monitoring, for mild aortic stenosis would be 3 to 5 years, moderate aortic stenosis 1 to 2 years, and severe asymptomatic aortic stenosis every 6 to 12 months. But as a clinician, you'll likely want to touch base with your patients more often than that to make sure that they're not developing symptoms. Now, these follow-up times obviously have to be adjusted if you have mixed valve disease or if there's new symptoms. It's important to reassess. Some key topics not covered today, and I had to put an ancient Greek quote, or else it wouldn't be a proper St. Michael's Hospital echo talk, is live to fight another day, paraphrased from Demosthenes. This is for Foti. And some of the things I haven't talked about today is additional level 2 recommendations from the ASC on parameters to assess aortic stenosis severity, and this includes calculations to account for pressure recovery and so on. And I haven't gone over dobutamine stress echo, how to perform it, and what parameters to look at in detail. It's also important to know that CT can be used to help as a tiebreaker, particularly in the low flow states, to look at aortic valve calcium to diagnose severe aortic stenosis, which has sex-specific cutoffs. as well as we haven't discussed the assessment of prosthetic valves, which was done in another talk by Taylor Petropoulos. We haven't touched on dynamic LVOT obstruction, indications for aortic valve replacement, selection of aortic valve interventions, TAVI versus surgical aortic valve replacement, or selections of types of prostheses, such as bioprosthetic versus mechanical. So some of the take-home points for today's introduction to assessment of aortic stenosis with echocardiography are to search multiple windows and look for the most parallel flow to assess for the highest possible velocities. This is important because the downstream effect of this is that your other parameters are mostly affected by this one measurement that you do. You need to assess the key valve parameters that we talked about, your Vmax, your mean pressure gradient, your aortic valve and aortic valve area index, and your dimensionless index. And it's important to put these findings in the context of the overall echo and the patient. So if your LV systolic function is reduced, don't forget to look and think about low flow, low gradient aortic stenosis. If you have a low stroke volume index for the body surface area, think about paradoxical low flow severe aortic stenosis if your aortic valve area suggests severe ES, but your gradients or flow are not meeting that cutoff. Important to look at the aorta, the diameter for aortopathy, which has its own set of surgical indications, as well as the phenomenon of pressure recovery, which we touched on today. You're also looking, of course, for other valve disease. We talked at the beginning of the presentation about the presence of mitral valve rheumatic disease when you have mitral valve aortic disease, which is in about, I think, 90% or so of cases is what I've read. And also thinking of things like things that can decrease your stroke volume coming out of your LVOT. So if you have severe MR, you may actually underestimate the stroke volume coming out of the LVOT. And of course, looking at the other valves, if you're referring to surgery, to make sure that you're pointing out all the different valves that may need an intervention. And for clinicians, of course, looking for symptoms. Don't forget about decreased exercise tolerance. Patients will say that they are not short of breath, but they're potentially not walking anymore because of their shortness of breath. So making sure that you're not missing symptoms because patients have become sedentary to avoid their symptoms. And of course, considering follow-up frequency. These are some of my references. Thank you very much for the opportunity to come talk today. I'm happy to take any questions or comments.
So thank you, Nick, for this very comprehensive review of aortic stenosis. Provides a very good basic approach to the problem. And just a reminder that we have a new section in the virtual echo rounds on our YouTube for newcomers to echocardiography. So there's a series of lectures that are geared towards people new to our field to provide an introduction to the various areas of echocardiography. So without further ado, let's open this up to our audience and see if there are any questions.
Qiming, it's Bob.
Yes, good morning. Please go ahead.
Good morning. So great talk, Nick. And I think you made, all of the important points have been made. I guess maybe a comment. One of the problems with aortic stenosis in the echo lab is the follow-up. So we get studies where, we're seeing the patient, annually or whatever, and following along the valve and following the gradients and looking at calculating the aortic valve area to give the attending clinician some sense for whether the valve area has become severe and whether or not that should raise concerns about timing of surgery and so forth. So I think you've raised the issues with the follow-up, of course, is that if you don't get the peak velocity and the right peak velocity, that's a problem. Everybody knows that. And I think one of the things we don't do very well is document where we got the peak velocity, so that if you're comparing it, if it actually in one case was achieved at the right sternal parasternal border, we don't necessarily always know that, and I'm not sure that we always work hard to get that same spot, for the peak velocity and the follow-up studies. So I guess that's one point. The second is which I think is a real problem, is the left ventricular outflow tract dimension measurement. One of the things you have to be careful to do when you're looking at an aortic valve area that's getting worse is to make sure that the LVOT measurement is the same. I think one of the maxims that I think we agree on is that the LVOT doesn't change in size over time. It's whatever it is at the beginning, it should be at the end. And sometimes we don't pay attention to that. And if the LVOT measurement is smaller on a follow-up echo, the valve area will be smaller, and that may precipitate a view that the valve is getting worse when in fact it hasn't changed. So where we measure the peak velocity and that LVOT measurement are particularly important when you're looking at following a patient along over time. And I guess my final comment would be, and you mentioned this as well, but just to emphasize, the amount of calcium in the aortic valve matters, and especially with degenerative aortic stenosis. And if you're sort of struggling with the valve area or not sure about we really got the peak velocity, for example, so maybe we're underestimating how severe the valve is. If there's a ton of calcium on the valve, that should be a trigger to sort of suggest that this valve may be even worse than the valve area we're getting would suggest. So you mentioned that CT will give you a number, but even on echo, you can look at a valve and see that it's heavily calcified, and that should raise alarm bells that if the valve area is not coming out that severe, it may actually be worse than what we're getting. So a comment on the amount of calcification of the valve, I think, is also helpful in helping the attending clinician to decide whether this stenosis is truly severe or not.
Thank you, Dr. Howard. Completely agree with those points about searching for that max velocity, which is why I found that beautiful illustration from 1985 so pertinent, because this is a long-standing issue that really involves a lot of work into trying to find that spot. And again, agree with the LVOT. I find myself retracing LVOT measurements over and over again to try to make it make sense compared to prior echoes. And finally, the point about CT calcium, as well as seeing that valve is quite calcified. I didn't show a very, very calcified valve today in terms of the clips, but certainly some valves can get quite calcified, and it should raise suspicion. Thank you.
Yeah, I want to echo the comment that the LVOT measurement is very important. We measured at the leaflet's attachment point to the annulus. We used to measure it about 0.5 centimeters away from that point, and but on the other hand, at that area, we find that subsequently that the area is not as circular or more elliptical around that area, and also the fact that if you measure at where the leaflet joins the annulus, is more reproducible and more circular, so that from time to time the measurement is more reproducible. So we actually in our lab we move back and forth on this point of where to measure the annulus, or rather the LVOT, for the calculation of the aortic valve area, and most recently we have moved back to where the leaflets touches the LVOT. So the other thing is important when you're reporting, and this has a lot to do with our sonographers. We're really dependent on your efforts in documenting where you actually measure it and where the maximum velocity is, so that in the next set of echoes or follow-up echoes, we can reliably go back to the same area and look for the maximum gradient. And last but not least, the introduction of Doppler velocity index or DVI becomes very interesting in the last 10 to 15 years, because with that, the LVOT measurements become, less reliable or less dependent on the measurement of the LVOT, because the DVI is actually a comparison of V1 and V2, but yet the velocity are very important to measure properly, both in the VTI as well as the Vmax. And but the DVI actually allows you to compare studies from one to the other, as well as very important in the prosthetic valve, because measuring the LVOT in the prosthetic valve is actually very challenging with all the shadowing. So very happy that DVI Doppler velocity index has been more popular these days than when I first started. Any other comments?
Shiming, maybe one more comment from me, and it's about dobutamine echo for low flow, low gradient assessment. And just to say, for those who've never done it, it's, it sounds easy. It sounds like it's a great solution, but just to say, it's really hard to do. And one of the problems with dobutamine is it's not a clean drug. So what you want is the stroke volume to go up. So you're hoping that dobutamine causes increased contractility, so your stroke volume goes up, so you can sort of assess, whether the valve area, stays the same or gets bigger, given that it's low flow. But the problem with dobutamine is it also increases the heart rate. And actually, for stress echo, we use it because we want the heart rate to go up. So the problem with increasing doses of dobutamine is sometimes the stroke volume goes up, sometimes the heart rate goes up. They don't go up together, they go up differently. So they're hard to do. It's multiple measurements that you're making. It's not easy to do. And I think maybe less useful than some people like to think it is. And obviously you're making multiple measurements again, V1, V2 every time, and they all need to be perfect. So just to say that we talk about dobutamine being a nice solution for low flow, low gradient, challenging, I would suggest.
I would completely agree with that, because there are actually many variables involved, as many of you know. So, from one measurement to the other, the tracing, and in our echo world, we have a number of situations like this, including the CRT, echo optimization, and so on and so forth, as well as now with the dobutamine stress echo with low flow, low gradient AS. So those are the couple tools that we have in our armamentarium that has more variability than the others. But having very, very meticulous application of it is very important, and we try our best to help resolve these conundrum. But having CT and the calcium score can also help in the discussion as well. So you have to put all the pieces of puzzle together.